Welcome to ACOG's Video History Project. We're very fortunate today that we have as our guest Dr. Richard Waldman. Dr. Waldman was the 61st president of ACOG. And Richard, thank you for coming, willing to be interviewed.
My pleasure.
We'll preserve you for posterity.
That's a scary thought.
Well, let's go back and get a little history about who you are for our viewers in the future. Where were you born?
Newark, New Jersey.
North New Jersey.
Yeah.
And after that, did you live in New Jersey all of your early life?
I lived in New Jersey until I graduated from medical school. And then I came to Syracuse, New York for my internship in surgery. And during my year in surgery, I decided to be an obstetrician and gynecologist.
Well, let me take you back just a little bit before there. What made you decide to be a physician in the first place?
It's a funny story. My mother gave me three choices. She said I could be a doctor, I could be a dentist, or I could be a lawyer. I had an older brother who was a surgeon and a middle brother who was a dentist. So I decided just to go into medicine. Easy decision.
All right. Now, did you go to Syracuse for undergraduate?
No, I was at Rutgers in undergraduate, and was at now it's the Rutgers Medical School, but it was the New Jersey College of Medicine and Dentistry for medical school. And then I came up to upstate for my internship in surgery, and then stayed there for my residency in obstetrics.
Well, now you said you started an internship in surgery.
Mm-hmm.
When did you decide to change and go into OBGYN?
In the middle of that internship year, I scrubbed on a Whipple procedure, and I realized I didn't have my heart in assisting. And I figured if I want to be a surgeon, I better be excited about doing a Whipple operation. So I changed during the middle of the year, and they accepted me in the program in Syracuse.
Who was your chair at that time?
Robert E. Lee Nesbitt, and for the 4 years.
A very famous OBGYN at that time.
Yeah.
Now, when you finished your residency, what did you decide to do?
You know, my brother was drafted into the Air Force, and so I decided to join the Berry program, and I spent 2 years in the Air Force. 1 year in Austin, Texas, and 1 year at Altos, Oklahoma. Two good years.
What type of experience did you have in that?
Well, in Austin, I was just a gynecologist, all by myself, no anesthesiologist, just a nurse anesthetist, and I got my first surgical experience. And then in Altus, I was all by myself and doing obstetrics with no support whatsoever. Remember the Air Force, they told me I couldn't put the baby on mom's abdomen because it was against Air Force regulations.
There were many regulations about that in those days.
Yeah.
Tell me a little bit about the type of practice that you had besides that. I mean, was it almost all ambulatory with a little OB and a little GYN, or was it?
In the Air Force?
Yes.
Yeah, it was almost all ambulatory. In the first year, it was all ambulatory and general surgery, gynecological surgery. Then in the second year, it was OB and GYN.
And then when you got out, what did you consider?
Well, I considered going into an academic program in Syracuse. We were trying to get back to the East Coast, and that didn't fit me as well as I thought it would. And so I went into actually a closed panel HMO for 3 years, and we had a practice that was outside of town, about 25 minutes outside of town, and we used to go in, deliver babies, go back out to the practice, see patients, go back in, deliver babies, go back out to see patients. So for 3 years, I worked in a closed panel HMO, and then we opened up a private practice.
Now, you said we when you mentioned a minute ago. I happen to know you're unique among all the presidents we've had that you were married to a midwife as well.
Yes, absolutely.
When did this occur?
Well, that didn't occur right away. I mean, we started working, actually, Elaine was a nurse practitioner when I was moonlighting while I was in residency, which they used to allow the residents to moonlight in family planning clinics, and we met there. And then when I realized I was going to be so far out of town for delivering babies, I asked Elaine if she would come join me, and she said, yeah, fine, but I'm going to become a midwife. Would that be okay? And I said, absolutely. And the next question is, well, what is a midwife? Because I had never heard of a midwife before, and that started a journey. When Lynn came back after her midwifery school in Charleston, we had no hospital privileges in all of central New York. And it took us a long time, over a year, to get hospital privileges in the hospital. It was an exciting time. Midwifery was not accepted in our community, and there was the closest midwife is in Rochester, in Buffalo. Henry Theod had started the midwifery program in Mississippi and then moved to Strong. So that was somewhat of a support system, but also there was a midwife in Buffalo. Those were the closest. So.
And during your presidency, one of the things that you accomplished was a much closer relationship between the American College of Nurse Midwives and the American College of OBGYN, which still exists today. Why did you take that on?
Well, we saw the beginning of the relationship between the obstetricians and gynecologists and the midwives as being very fractured, a lot of distrust. And I worked early on in the Collaborative Practice Committee, and they didn't include midwifery on that committee. And it took us a while to get a midwife on the committee. And we finally did it at the end. And so I recognized that we could have a much stronger relationship with the American College of Nurse Midwives, because we had a lot of people within our community, obstetricians and gynecologists, that were very, very supportive. And I think it's one of the things I'm more proud that we were able to accomplish. We put together that joint statement, which was an interesting challenge. And the actual challenge was that we came to the table with a very generous concept of what the joint statement should be. And the midwives had been so distrustful of us at that particular time, they actually turned down what eventually became the joint statement, thinking that we were trying to, do something underhanded. And which is surprising. I mean, because we came with, I think, goodness of our heart. We thought that was a great time to change the relationship. And in the end, I think you know that it was very successful. And that people point to that joint statement as a fine example of collaboration, and we almost didn't get it.
I think you should be very proud of that relationship development, because it has gotten much, much better. Where do you see it going in the future?
Well, I think midwifery will become a much more important part of the obstetrical matrix in this country, because I think more, you know that in other countries like the United Kingdom, midwives deliver more of the babies than we do here, and I see that relationship just getting stronger and stronger. It's mutual respect. When you have mutual respect among professions and you lose the distrust, you can build the relationship stronger. One of the heartwarming things that occurred while I was president is we called this meeting together. And I think you'd have to know how difficult it was in the beginning for me as an obstetrician gynecologist to support midwifery in a community that did not support midwifery at all, didn't know what it was, and was very distrustful of it. And I grew up in that kind of a setting. And we had this committee that we put together about midwifery, and we went around the table. And everybody at the table was totally supportive of the midwife and the physician-midwife partnership and collaboration. And I actually became, a little bit tearful at that we had seen that much change in a number of years. And then we were talking about, small programs. We were talking about Parkland in Dallas, and I really had never realized that the midwives and the docs had developed such strong relationships across the country. It was a very heartening thing for me to experience.
Let me take you back to your training days a little bit. We all know that when we're in training, we rely heavily on mentor. Who were some of your mentors that you felt really influenced you?
You know, the mentors that I had, there are two that stand out, and they weren't in training. One was Ed Gibbs from Texas, San Antonio, at that time. Ed was on the quality committee, and I had been doing quality in my institution. And so I came to the VRTC program in its very early days. And Ed Gibbs was he was the director of that program. And he took me under his wing, more or less, came to visit us in Syracuse. And he was just a very, very special guy. And the other person who brought me under his wing was John Choate, who was the former chair of District 2. And John, you know, without John's support and without Ed's support, I wouldn't be where I am today.
Let's talk a little bit about your college experience. What was your first position in the college?
The first position in the college was in the quality, the VRQC program, which was just getting started. I think it was Mixon was the president back then, and it was his idea to start a quality VRQC program. And I had been doing a lot of quality work in my institution, and the chair of our section at that time was a fellow by the name of Pierre Risk, and Pierre recommended me for the VRQC program. And I'd never been involved in the college in any way at that time. We felt very strongly that the practicing obstetrician gynecologists need to be represented both at the federal level and the state level. And so a lot of the people were trying to represent us, and they were representing us well, but they couldn't speak what was happening every day in practice as well as I could. And so I made a special point, because I was in private practice and not in academics, to take those roles and to do whatever I could in order to promote the specialty.
And after the VRQC, what other positions did you have?
I was on the collaborative practice committee. Then there was a quality committee, and eventually I ended up on the finance committee.
And from there?
From there, I became the district chair at District 2.
But before you did that, were you ever a section chair?
I was a section chair. Yes, I was a section. That's right. I was a section chair, and I moved up from the vice chair to the section chair, and then the section chair to the secretary, and then I jumped from the secretary to the vice chair of the district because somebody left, and then I became chair, as you know.
Yes, but let me ask you a question then. Why did you want to become president of the college?
That's an interesting question. I remember sitting at the executive committee, and I would never, ever think that I could be president of the college. Ever. I mean, it was never anything in my mind or in my thought process. And I remember one day sitting at the executive committee, and I recognized that my experience in private practice, and my experience in District 2, which, as you know, is a little bit of a different district, gave me a background that really gave me an opportunity to see obstetrics and gynecology in an interesting way, but it also gave me background that in so many of the different issues that we face. Collaborative practice is one, liability is another, quality was a third. And I recognized that not everybody at the table had that background. So I all of a sudden, it's just, I mean, to think, even today, I shake my head at the thought that I became president of the college, because that would be nothing that I would ever dream of.
Besides the midwife issue, which surfaced during your presidency, were there any other issues that you recall that were major that you had to deal with?
Well, quality, we were always, District 2 in New York has always been tried to be out front on quality and safety issues. So when I became chair of New York rather suddenly, I recognized that we were not going to advance the liability issue in the state. Liability in New York State is very difficult. The lawyers are very strong, and it was a huge issue for us. So I went with the first meeting with our director, and I said, we need to do safety and quality, and she looked at me like I was crazy. But I recognized right from the very beginning that the only way to keep doctors out of trouble was on the safety and quality issues, and they have to keep them out of the courtroom instead of defending them after they get into trouble. And so we spent a lot of time in New York on that, and I think that was something that I tried to push forward when I was the chair. And obviously the liability issue in New York was rather major at that time.
As I recall, at that time, we were dealing with big issues on Long Island and some rather difficult times for the college in New York that you were having to handle.
Oh, my goodness gracious. The first meeting that I went to, I was in New York City, and I even though I grew up in Newark, New Jersey, which is really downstate, just like New York, I had been upstate for many, many years, and I went to my first meeting, and I was the vice chair, but the chair wasn't there, and they were meeting on liability, and I'd never seen anything in my life like the docs going after each other. They went after our treasurer at that time, who was there. Penny was there. The treasurer was Tommy Rowland. He came to do a nice thing for the college by showing up, and they started attacking him on the liability issue, and they started attacking Donna Montaldo at that time on the quality issue, on the liability issue, and I had never seen anything quite like it in my entire life. And I tell a story often that I had to think on my feet, and when I came up and I said, well, thank you everybody for being here. I know you're very interested in this. I said, when you get up and talk, just tell me two things. Tell me how much you're going to donate to the PAC, and tell me how many times you've been to Albany and how many legislators you've talked to in the past, so we know what your experience is. And that ended it. Penny was in the room. I remember, you can't donate to the PAC. I never had any intention of donating to the PAC at that time, but it stopped the conversation. It was really going downhill. I mean, people putting fingers in other people's children. That was a wake-up call to leadership in New York. And then we had a schism between downstate and upstate. Downstate was going through some very difficult liability issues, and they thought the college wasn't doing anything, and in actuality, we had been doing an awful lot. We just hadn't been successful, and we had to support them during this period of time tenuously, not being happy in the direction that they were going, but recognizing if we didn't support them, that they would divide the state up, and so we were able to get through that.
Let me take you to the future a little bit. If a medical student comes into your visit with you today and says, I've been thinking about going into OBGYN, what do you think? What would you tell them?
This is the most fantastic specialty. I mean, this experience for me, forget the presidency of ACOG, which is not an insignificant factor in my life. But every day in the office, I'm still seeing patients, and some of the patients I've been seeing for 35 years. And they come in, and this week, a woman came in and said, thank you for referring me to the surgeon because they diagnosed the thyroid cancer and you saved my life. And another patient came in and said, my child was born 25 years ago with a deformity. And you stayed up with me for hours and reassured me that she would be fine and she would be okay one day. And I just want to tell you that she just graduated from law school and she passed the bar. She was number 5 in the country on the bar exam. And I remember that night like it was yesterday, that I was so distraught and you reassured me that it would be okay. And it was okay. And we enter people's lives every single day because we're that intimate contact. We're not their family doc. They trust us. They get undressed in our examining rooms, and they trust us in a way that very few people are trusted, and it's an important trust relationship. And we're not general surgeons that have this little small relationship with the patient, comes in, the patient goes out. We have this long-term relationship with women and families that is really remarkable. So I would say yes, go ahead.
Now that we talked about that, obviously I agree with you that this is the best of all specialties, but what do you see as the most negative aspect of our specialty?
Right now, our physicians are stressed beyond stress. And it's not just because they're obstetricians and gynecologists, although some of it is liability that drives them. Still, in New York, it's still a big problem, and I don't want to diminish that. But the electronic medical record is really distressing so many of our people. I think it's sort of like robbery. They're being robbed of their time without being paid for it. They spend all their hours filling out these records, and then at the end of the night, they go home and they fill out the records even more and go through their lab work. So they're working 2 or 3 hours extra every day in order to get the electronic medical record. It's very frustrating. And that's not our specialty. That's almost everybody's specialty today.
What do you see as the future of OBGYN?
Well, I'm concerned. I'm concerned about the changes in the pap smear requirements. I'm concerned in the changes in mammograms and suggestions that mammograms aren't as useful. I think we've done a fabulous job in women's healthcare today. I think we've gotten to a point where, you know, I haven't really seen a cervical cancer in 25 years. I've seen precancer, I've seen carcinoma in situ, but I haven't seen a cervical cancer in years. And I'm afraid that if you go for your pap smear every 3 years, maybe you'll remember to go for your pap smear every 6 years or every 10 years, or maybe you won't remember to go at all. And I'm concerned about that. I think we need to support the obstetricians and gynecologists of today in a way that supports what they do every day, examining women's relationships with women, guidance to women. And I'm afraid for the specialty, but I'm also afraid that we're going to lose all the things that have given us the advantages in breast cancer and cervical cancer and all the other things that we do every day. And I see tremendous opportunities. We just need to grab them. I think genetics is going to be a huge future for us. And I hope we grab a hold on genetics and understand how important it is every day in everyday practice.
Do you think that we will reach the point where every patient will ultimately get a genetic screen?
Yes, I do. I think that's going to come. I really do. You know what? The progress that's being made there is really, that's why we're so lucky sometimes. We're experiencing this. 10 years ago, 7 years ago, we had lectures on the importance of genetics. And even today, it's 7 years later, and the changes that have occurred since that time are really very remarkable. It's really, both in prenatal, but also the cancer genetics is from both the treatment point of view and for the screening. We now screen every patient that comes into the office for history on cancer. And it's a detailed history that's really changed the way we're practicing.
Richard, I appreciate very much you're willing to come to us today and share with us your story. You were, as you know, I loved your presidency. It was a time of crisis, but it was also a time where we made, I think, significant changes. You were one of the first advocates of a PAC, which we now have, as well as our collaborative practice, which has done so well. I think you should be very proud of that. Thank you very much for being here, and hope you still continue to have a long and successful practice.
Thank you. My pleasure.